Okay, good afternoon, everyone. We have it the third webinar of this new edition, and it's my really great pleasure and joy to introduce the new speaker that will be describing his amazing job and, of course, everything has done by Professor Kholová. So thank you everyone for being here. It's for many of you and including me, it's my last day of summer. So thank you especially to Mauro for this new, very exciting webinar about the reporting pancreaticobiliary cytopathology. And thank you, Ivana, for introducing.
Okay, it's a great pleasure and honor to introduce Professor Mauro Saieg. His current position is Associate Professor at the Department of Pathology and the Jewish General Hospital of McGill University in Canada. Previously, he was in a Samba country in Brazil, where he was cytopathologist and Associate Professor at the Santa Casa Medical School in Sao Paulo. Then he moved to the polar area, and he has also very many international functions. He is currently serving as Associate Editor of Cytopathology Journal, and he is very active, being published more than 80 peer-reviewed articles in journals and giving many talks and international forums. Mauro, it's your turn to continue.
Thank you very much. Thank you, Gianna. Thank you, Ivana, for inviting me. It's really an honor to be here and present you the WHO system for reporting pancreaticobiliary cytopathology. And yeah, I would like to thank the IAC too. So let's go. So before we start talking about the WHO, we have to acknowledge the Papua-Nicolau Society of Cytopathology system for reporting pancreaticobiliary cytology, and the WHO reporting system was based on this first classification. So during the pandemics, we switched from one to other. There is a group of authors and editors, and I had the pleasure of being part of that group that managed to organize and divide the chapters of the WHO system and then put it into place. What has changed in the WHO system when comparing to the Papua-Nicolau Society of Cytopathology system? Basically, when we compare it in the WHO, we have three terms for non-diagnostic. So we can either use insufficient, inadequate, or non-diagnostic. Of course, it depends on the client's preference. So I know many clinicians in the hospitals don't like the term non-diagnostic. They prefer inadequate, or sometimes they prefer insufficient. So it's really up to the client and the person who is signing out cases. All the cases that were classified as benign and negative now are negative for malignancy. Atypical is the same. And I guess the biggest change was the category that was once called neoplastic benign and neoplastic other in the PSC system. The neoplastic benign became negative for malignancy. And the neoplastic other, now it's divided into pan-low and pan-high. The majority of those cases are mucinous cystic neoplasms. We're going to talk about it. But those cases now are divided into neoplasms with low risk, low grade, that's called pan-low, and the neoplasms with high risk, high grade, pan-high. Suspicious, remain suspicious, and positive continue to be positive, but one big difference is that neuroendocrine tumors and solid pseudopapillary neoplasms that were once classified as neoplastic other, as a tumor with uncertainty risk of malignancy, now they're called positive. So they are under the positive category. And this is because the WHO system for reporting cytopathology goes in resonance with the WHO system for histology. So since in histology, these tumors are classified as malignant, in the cytopathology system, we also classify them under malignant. And of course, we have some additional chapters on risk of malignancy and management. So starting from the beginning, as we always do, when we talk about insufficient, inadequate, and non-diagnostic, the main thing about this category is that it's usually when we don't answer the clinician's question. So for example, if we have only epithelium from the needle tract, or we only have normal elements of the pancreas on the setting of a pancreatic mass, or when we have an acellular aspirate of a solid mass and an acellular aspirate of a cystic mass. So in these cases, we call these cases insufficient, inadequate, or non-diagnostic. I prefer the term non-diagnostic. Anyways, what is the main problem with this category is that when we see only normal components of the pancreas, as in here, that we only see normal ductal cells, but we have a well-defined mass lesion in the pancreas. In this context, we have to call this specimen non-diagnostic. We cannot say it's negative because they're only normal samples, because there is a well-formed mass in the pancreas. So the first rule of cytology is we can only call something negative if we have enough adequate material. So in this case, we don't have adequate material. In this case, we only have normal elements of the pancreas. So if we only have normal elements of the pancreas and we have a well-defined mass, it means that the needle is not targeting the lesion. So it means that this case should be classified as non-diagnostic. These are examples of gastric contaminants. In this case here, club-shaped rim of cells in the periphery. Gastric contaminants sometimes may be difficult to distinguish from normal epithelial cells from pancreatic cysts with mucinous components. One hint for gastric contaminants is this club-shaped strip of cells in the periphery that are very well organized. For duodenum is a bit easier because you see the geometric appearance of the goblet cells, and that is a bit easier for you to recognize that material as duodenum. But it's very important to know where your needle has been. So if it's a lesion in the head of the pancreas, most probably the lesion went through the duodenum. If it's a lesion in the tail of the pancreas, the needle went through the stomach. So we have to know where the needle has been. So we have to identify what is contaminant, either from gastric or duodenum epithelium. And when we have that, and this is what I called macroscopic on-site examination, right? MOES. When we have mucin, thick mucin, this is diagnostic. So even if we don't have epithelial cells, if we have very high thick mucin, as we call it in the Milan system, as we call in other systems, this represents a neoplastic lesion, mucin-producing neoplastic lesion. So with this type of mucin, you have to call this lesion neoplastic, mucin-producing. If it's low grade or high grade, of course, it's going to depend on morphological assessment, but this is diagnostic. This is not non-diagnostic. For this category, of course, we have to correlate with clinical aspects, and the risk of malignancy is very high. You're going to notice, as a matter of fact, when we are talking about pancreas, that the risk of malignancy of the categories is usually way higher than from the other targets and other sites. And this is why, and this is because pancreas lesions are usually neoplastic, usually malignant. So whenever you find a mass in the pancreas, unfortunately, most of them are going to be malignant. So even if you say it's non-diagnostic, the risk of malignancy is still high. When we call about benign, so when we say benign negative for malignancy, we have to see cells that have no sign of atypia. So if we have benign epithelium, but in this setting, benign epithelium with a vague mass on imaging. So again, if we have a very well-formed mass on image and we only have benign epithelium, it's better if we call it non-diagnostic. But if we have a vague mass on imaging and we have benign epithelium, then you can call it negative, usually with a note saying that only normal epithelial cells from the pancreas have been found. So it's better to correlate with clinical and radiological information. It's very important when we are dealing with pancreas to have all the clinical and radiological information all together. We're going to talk about cysts in a while, and for cysts, it's mainly important for us to have all the clinical information, all the levels of cysts and CA, amylase, and glucose done in the cystic material, because then we can manage the clinical information, the radiological information, and morphological material all together and achieve a proper, definite diagnosis. Of course, inflammatory processes are within this category as well: pancreatitis, presence of pseudocyst, lymphoepithelial cyst, accessory spleen, and some benign neoplasms, the most common being serous-cystadenoma and some other more rare neoplasms like schwannoma, lymphangioma, and lipoma, for example. So this is the normal sheet of ductal pancreatic cells. They have this honeycomb pattern and very well organized and dispersed. Sometimes we can see lots of inflammation within it with some lymphoepithelial lesions, and this is called pancreatic lymphocytic pancreatitis. It's very hard to differentiate it from IgG4. Sometimes if you have immuno, it might help, but the diagnosis of IgG4 mediated pancreatitis is mainly clinical, and you're probably going to say it's a lymphocytic pancreatitis. Accessory spleen is another possibility of needling when you're dealing with benign lesions. It's very important to remember because, of course, you're always going to think about pancreas, but accessory spleens do exist, and sometimes they may form suspicious masses on the ultrasound, and the patient and the clinician might think it's cancer, but once you put your needle in, what you have is lots of lymphocytes, lots of blood, reactive population of lymphocytes, small capillary vessels. And if you have a core biopsy or a cell block, that's very helpful because this capillary cells, endothelial cells, are going to be CD8 positive, and it's going to give us a proper diagnosis of accessory spleen. Pseudocysts usually come with a history of pancreatitis. So this patient have destruction of the pancreas with the formation of a cystic lesion or a cystic area. It's usually lots of foamy macrophages with a dirty background, and usually the amylase level of these lesions is very, very high. Serous-cystadenoma, it's the most common lesion when we are dealing with benign cystic lesions. Serous-cystadenoma, we usually have those foamy macrophages and this hemosiderin-laden macrophages, as we see here. So this lesion is very well vascularized, lots of blood, and it's very common for us to see macrophages with hemosiderin in the cytoplasm. Sometimes that's the surrogate marker for calling something serous-cystadenoma. Most of the times, to be honest with you, the clinician already knows it's a serous-cystadenoma because the radiological aspect is very clear. So they know it's serous-cystadenoma. So they just come to us and for us to confirm it's serous-cystadenomas. The biochemical analysis of the cyst is kind of washy-washy. It's not very clear. So CEA is not very high. Amylase is also not very high. Glucose is also on the fence, so it's not going to help you much. But if you have one slide with hemosiderin-laden macrophages and one image that looks like a serous-cystadenoma, you can say that it's most probable or compatible with. Sometimes you are lucky and you can find epithelial cuboidal cells, and if you have those needles like forceps biopsy needles that we sometimes have for cystic lesions, and we do have tissue, we can ask for immuno, and then the presence of those cuboidal cells that are positive for alpha inhibin and also GLUT1 is very helpful in identifying these lesions as serous-cystadenomas. Lipoma, it's usually another neoplasm that might be common in pancreas. I just brought one example here. So we have this tumor, have adipose tissue and pancreatic cells on the side, proving it's a lipoma from the pancreas. So important message. I have some of these slides here in my lecture. So if you are snoozing or sleeping and not paying attention, looking at your phone, come here now. So this is important. Important message for you. Remember, if we only have normal epithelial elements in a pancreatic cytopathology, we always have to go for radiology and ask the question, is there a well-defined mass or lesion? If there is not a well-defined mass, if it's a vague mass on radiology, you're going to report it as benign, and you're going to state that correlation to imaging and clinical is important. But if there is a well-defined mass lesion and the only thing you see on your slide are normal epithelial elements, you're going to report it as non-diagnostic. You're going to say a repeat aspiration is needed, and you're going to say that this patient needs further investigation because probably the needle didn't reach the lesion that we are seeing on imaging. So that's very, very important. So don't call something negative if you only have normal elements and there is a well-defined mass in imaging, okay? So for these cases of benign negative, the risk of malignancy is around 8 to 20%, and the management, of course, is according to diagnosis. Atypical is always difficult to talk about atypical because it's one area that you don't have neither quantity or quality of those cells to call it neoplastic. So it's in between. You are not sure if they are reactive or if they could be malignant. So you have to use with caution. It cannot be a wastebasket for sure. But it is necessary to maintain a high positive predictive value for the positive and suspicious categories, right? It's usually due to scant material and some artifacts. These are images from the book. So in here you can see some atypia, some cells that look clustered, and some irregular nuclei, clearing of the nucleoli, and we are not sure if this is only reactive in the setting of a lymphocytic pancreatitis or if it could be neoplastic. So in these cases, you can call it atypical, but it's always a tricky category, and it's based on not having enough cells with not enough atypia to call it malignant. And of course, we have to correlate with clinical and imaging always for pancreas. This is very important. You're never walking alone. You're never making a diagnosis by yourself. When you are dealing with cytopathology from the pancreas, you always have to have access to images and also access to biochemical analysis when we are dealing with a cystic fluid, because then we have clinical and imaging information together with the morphology analysis to conclude our final diagnosis. And as one might expect, the risk of malignancy for those atypical lesions is very high, usually a lot higher than from other sites. Now this is when it starts to get interest in pancreatic cytopathology. So what used to be the neoplastic other category that would comprise mostly mucinous cystic lesions, whether low grade or high grade, now we combine these lesions into the pan low and pan high. So this is the pancreaticobiliary neoplasm, low risk or low grade, and pancreaticobiliary neoplasm, low risk, high risk, high grade, right? So these are mostly cystic mucinous lesions, IPMN and MCN, and this is what we're going to be talking about. Usually they may represent pancreatic intraepithelial neoplasia, but this is most commonly found incidentally, and it's a very difficult cytological diagnosis for us to make. How do we deal with cystic lesions? Well, the first thing we have to say is that for cystic lesions, we don't perform rapid on-site evaluation. So rapid on-site evaluation is performed, and it's done for solid lesions in pancreas. For cystic lesions of the pancreas, it's a waste of time. You're going to waste fluid. You're going to waste material if you do rows. So we're not going to perform rows. We're just going to wash that material, and we're going to do a cytospan. When we do a cytospan, we're going to send some of the material for biochemical analysis, and some of the material we're going to send for doing a cytospan for grading and for looking at the cells. When we do biochemical analysis, we're going to do CA, amylase, glucose, and molecular study. Molecular study is indeed interesting, but not really necessary. If you don't have it, it's fine. KRAS is going to be mutated for mucinous lesions, and GNAS specifically for IPMNs. If you have the slide, then you can look at the slide, and then you're going to identify those cells and try to classify those cells into low grade and high grade. And that's the most important answer you're going to give to the clinician. Most of the times, the clinician already knows this is an IPMN because when they sample, they see it's mucin, they see it's thick mucin. There is a very characteristic image of IPMN with branches and communications with the main duct in the imaging. So they're going to come to you and say, this is an IPMN. I just want to know if it's low risk or high risk. If it's low risk, they're going to observe the patient and nothing is going to be done, just active surveillance. If it's high risk, probably you're saving the patient's life because you are identifying one lesion that is a very high potential of becoming an invasive adenocarcinoma, and you're making this diagnosis before it becomes an invasive adenocarcinoma. And we all know that, unfortunately, invasive adenocarcinomas have a very poor prognosis. So we are making this diagnosis before it becomes an adenocarcinoma, and you are potentially saving patient's life. So when we are dealing with cystic lesions, there is an essential correlation to imaging. We always have to see if they're unilocular, multilocular, or complex. That's very important. And of course, as more complex as they get, the more probable they are to be malignant lesions. Now, again, another important message: if you are snoozing, or if your son is calling, or if you're having a break to eat something, come back here and let's talk about cystic lesions and how we manage cystic lesions for biochemical analysis. So when we do biochemical analysis, we usually do those three. We do CEA, we do amylase, and we do glucose. If there is a high CEA, it usually comes together with a low glucose, and those patients usually have mucinous neoplastic lesions. And then we have to look into morphology. We have to see if they're low grade or if they high grade. And we can also test for molecular KRAS and GNAS. If that sample has low CEA, then we have to look at amylase. If it's a low amylase, it's probably a solid pseudopapillary neoplasm, a cystic neuroendocrine tumor. It could be a serosistadenoma, or it could be a cystic acinic cell carcinoma. And of course, we have to look at morphology and immunohistochemistry for those patients. If the amylase is high, then we're going to look at the pseudocyst, because that's most probably the diagnosis. And morphology, of course, is going to be a matching, and clinical info should always help because these patients have a history of pancreatitis. One thing that we have to be careful about is the lymphoepithelial cysts. Lymphoepithelial cysts may have high CA, but they are not necessarily mucinous lesions. So morphology is going to help us because we're going to see lots of lymphocytes and squamous cells. You're not going to see mucin, so that's not going to correspond to a mucinous lesions. Just remember that lymphoepithelial cysts might show high CA. So this is basically what we're going to look at when we are dealing with cystic lesions. So again, measure for CA, for amylase, and for glucose. And depending on your levels of CA, amylase, and glucose, you have different differential diagnosis. And of course, these different differential diagnoses are going to be decided upon molecular and morphology, and sometimes immunohistochemistry. But it's very important to have that in mind when we are dealing with cystic lesions. This is a low-grade IPMS, so that's a straightforward low grade. You see a very well-preserved NC ratio. The cells show very mild atypia, and when we are dealing with a high-grade IPMN, the cells are usually smaller, the NC ratio is higher, there is usually necrosis in the background. They may be figures of cannibalism, as we see in this picture. The nuclei is irregular, chromatin is irregular, and the cells are very small. And that's a very nice paper I always like to mention from MGH, saying that the high-grade atypia was the only statistically significant predictor of malignancy for those cystic lesions. So it's very important for us to identify high-grade atypia. And also from this paper, they list the morphological criteria for high-grade atypia, and most important are that it's a small size cell in comparison with a duodenal enterocyte. So don't expect to see larger cells when we are dealing with high-grade lesions. They're usually smaller. They have increased NC ratio. They have nuclear membrane irregularities. They have abnormal chromatin pattern, and they have a cellular necrosis most of the times. So these are the characteristics that can firmly make you sure that you are dealing with a high-grade lesion and not a low-grade lesion. This is very important because when you say the lesion is high-grade, the patient is going to be operated. There's going to go to surgery. And as I said before, you are potentially saving patients' lives. Some of these lesions already have an invasive component. So you are either diagnosing or interfering before it becomes an adenocarcinoma, or in a very early stage. And if the lesion is low grade, it's going to be active surveillance. They're just going to look for the patient and see how the cyst develops with the years. So That's very important. The risk of malignancy when we put everything together is around 40%, but of course that if we compare high grade and low grade, the risk of malignancy is of course going to be different. Okay. When we talk about suspicious, again, it falls short of a definite malignancy. I always show this triangle because that's very important for us to put everything together: morphology, imaging, and clinical info. So we have to combine the three of them to make a final diagnosis, because in this case, we are not, we don't have the quality or we don't have the quantity necessary to make this malignant. So we have to combine everything together. Sometimes morphology is very malignant, but the clinical info is not, or the imaging doesn't really go into malignancy, or the opposite. The imaging looks like a malignant lesion. The clinical info might make us think it's malignant, but morphology is not so clear, or cells are not so numerous, and we are not so sure. So in this case, we just take one step back and we call it suspicious, and probably saying that patient needs to have a reintervention. But most of the times, the clinician, when they know it's adenocarcinoma, they're very much pleased with this diagnosis, and they say, you know what, I think it's better if we just treat this patient as positive, because most of the times it's going to be positive. The risk of malignancy for this category is very high, about 90%. We can try to do some ancillary testing. SMED4, S100P have shown to improve specificity. P53 might help when specimens have P53 mutations and they have overexpression or the no type. And recently also there's been some papers talking about MTAP loss. That's a surrogate of the CDK N2A mutation. So molecular studies can also help too if you have not many cells, but maybe you can do NGS, and NGS shows characteristic mutations of pancreatic adenocarcinoma. You have one more reason to call it straightforward positive. But the risk of malignancy for suspicious is very high, around 92%. Positive for malignancies when we have unequivocal diagnosis of a neoplastic entity, and majority of them correspond to pancreatic ductal adenocarcinoma, but of course you also include neuroendocrine tumor, ACCs, and solid pseudopapillary neoplasms. In this case, we're going to do rows. So for these cases, we're going to do rapid on-site evaluation. So this is the example in the endoscopy suite. They are doing the procedure, and then we do rows. It's very important for us to separate in a slide what is tumor and what is blood. That's very important because you're not going to waste your time in endoscopy suite. You have to do the MOES. You have to do the macroscopic on-site evaluation, because otherwise what's going to happen is that material is usually very bloody. There's lots of material. You're just going to smear 10 slides. You're going to waste a lot of time looking at 10 slides. You're going to say, oh, this is mostly bloody. It's non-diagnostic. And the clinician is going to be disappointed. You're going to be disappointed. He might not call you again because it's going to potentially increase a lot his time of procedure. And he's going to say, well, this pathologist doesn't help me because everything for him is non-diagnostic. So I don't think it's helping me in my management. But if you do MOES, if you do the macroscopic on-site evaluation, and you look at the specimen, you can definitely say that there is a material there. There's a fragment, and the rest is blood, and you smear a part of this fragment, you're going to be able to really see what the cells are. If it's either normal pancreas, if it's a neoplastic lesion, and then with 1 or 2 slides, you're able to say, okay, so this is malignant, this is probably an adenocarcinoma, or this is probably neuroendocrine tumor, and we have to do this and that and that. So in that sense, ROSE is going to be very helpful. And how do we do it? So we usually do a fast H&E or Romanovsky stain. We look at those slides, we make a preliminary diagnosis, and depending on this preliminary diagnosis, then we send this material for whatever you want. So if we think it might be a lymphoproliferative disorder, we can send it for flow cytometry. If we think it's infections, we can send it for microbiology. We can produce cell blocks for H&E stains and immunos, and we can do liquid-based cytology for immuno, for fish, for everything we need. So with that in hands, and that's the true beauty of cytopathology, and that's why I'm very enthusiastic about talking about cytopathologists, because we have all material in our hands. It's not just like surgical pathology when you have just a paraffin block and you have to retrieve material from already formalin fixed paraffin embedded tissue. No, in here we have fresh cells. We have cells right from the source, and we can deal with those cells in a way that we want, depending on our preliminary diagnosis. So that's very helpful. That's very nice. And this is how we perform roles in our institution. So when dealing with solid lesions, one pattern that is very important for us to recognize is between dispersed cell population and 3D clusters of cells. Why this is important? Because when we are dealing with dispersed cell population, it's mainly a neuroendocrine tumor or solid pseudopapillary neoplasm or ACC. And when we are dealing with 3D clusters of cells, it's mainly adenocarcinoma of the pancreas, ductal adenocarcinoma. So this is a very important pattern that we have to pursue when dealing and when looking at pancreatic specimens. So in here, we can see that we have dispersed single cell population. So that's most probably not adenocarcinoma. This falls into the main differential diagnosis of PNAT, ACC, and SPN. So in here we have those cells that are isolated with somewhat irregular chromatin, with this salt and pepper type of chromatin. One thing that is very common and important for those lesions, I'm going to go back again, is that the nuclei usually tends to go out of the cell. So the cytoplasm tends to finish in the middle of the nuclei, and then some part of the nuclei tends to be a bit out of the cell. That's very characteristic for neuroendocrine tumors. It's very important, of course, for those cases to have a proper cell block, and with the cell block, we can do immunos. So we can do chromogranin, we can do INS1, we can do synaptophysin, and we can make a final diagnosis of neuroendocrine tumor. Can we grade neuroendocrine neoplasms in cytology? Well, if we look at the WHO proposal for grading pancreatic neuroendocrine tumors into G1, G2, and G3, it's based mainly on counting mitosis and Ki67 in hotspots. It doesn't really use necrosis. So yes, we can. The problem is that we're not going to have the hotspots because it's a cell block, so it's not a surgical specimen where you can look for areas specifically. And we can count mitosis as long as we have lots of cells and lots of material. So it's really basically a matter of if we have enough material to say that it's feasible for counting mitosis and looking for Ki67 areas, and then we can say that we can promptly say that it's G1, G2, or G3. We make a very good concordance with low-grade neoplasms, but we underestimate high-grade lesions, of course, because sometimes there must be some high-grade areas that were not sampled in the cytological specimen. But I mean, if we have enough material, if you have lots of material, you can try to say this is low-grade or this is high-grade. But most of the times, if you have not enough material, just call it neuroendocrine neoplasm, neuroendocrine tumor, and then you're going to properly classify it in the resection specimen. So this is one example of solid pseudopapillary neoplasm. That's the classic papillary appearance. When we have papillary lesions with a vascular axis and the cells are dispersed within this vascular axis, sometimes you can see the dispersed single cell population that's very similar to neuroendocrine tumors. So you got to be careful with this. When we look at this area, you may think, well, this might be a neuroendocrine tumor, this might be a solid pseudopapillary neoplasm. So we have this dispersed pattern. Of course, that for the solid pseudopapillary neoplasm, the nuclear features of irregular chromatin are not going to be so clear as the ones we see in neuroendocrine tumors. And again, when we look at those features, we can go from one to the other, but immunohistochemistry is the main thing that we have to do for those cases when we have this dispersed pattern of isolated cells, and it's hard for us to distinguish between neuroendocrine tumors and solid pseudopapillary neoplasms. And whenever we have a good cell block, we can ask for immuno. Beta-catenin is going to be positive in the nuclei, but my preferred immunostain for those cases is CD99. CD99 is going to have a perinuclear dot-like pattern that is very characteristic of solid pseudopapillary neoplasms, right? So when we think of ascenic cell carcinomas, those cells have similar features to neuroendocrine tumors and solid pseudopapillary neoplasms. They are low-grade, mostly monotonous. They sometimes may form irregular cytoplasm, irregular nuclei, and some nucleoli. And if you're lucky, you can see zymogen granules. And here are the nucleoli that may be found in these specimens. Small cell carcinoma, it's very straightforward for us to make the diagnosis, most commonly encountered in the pancreas in this form of small cell, very similar to what we see in Merkel cell carcinomas or in small cell carcinomas of the lung. Mitoses are frequent. You can see paranuclear blue bodies. You can see molding, lots of necrosis. K67 is going to be very high. This is one case that I had of a mixed ACC and neuroendocrine carcinoma. So for the areas of neuroendocrine differentiation, chromogranin was positive, and for the areas of ACC, trypsin was positive. So that's very classic and very nice of a mixed combined tumor. Again, important message. So we are here. You've survived for 35 minutes already in this IAC webinar about pancreas. And we know pancreas is difficult, and you are here because you want to learn important stuff about pancreas. So this is the important message number 3 that we have for you. So let's go. When we talk about immunohistochemistry, everybody, this is very usual and very useful, for distinguishing between these 3 different diagnoses that we usually have similar morphological features in pancreatic cytopathology. So for us to distinguish between ACC, PET, and SPN, for ACC, BCL10 and trypsin is usually positive. For PET, INSB1 and chromogranin, and for SPN, beta-catenin and the CD99 with the dot-like paranuclear staining. So those are the markers that I usually use. I know that most of the times when we are dealing with pancreatic cytopathology, we have scant material. So we don't have lots of material. The cell block is not very rich. The clinician just went 1 pass or 2 passes, and there wasn't enough clinical conditions for him to continue the procedure. So it was very difficult for him to get more material. So we have to be very wise in selecting which are the markers that are going to be most helpful for us to achieve a final diagnosis. So if I had to choose 2 markers per differential diagnosis, that's what I would do. Those are the cases that are mostly likely negative in one and most likely positive in the other ones. And of course, together with morphology and clinical information, you are able to reach a definite final diagnosis. Talking about adenocarcinoma, this is a nice example that we have on the left normal ductal cells, and on the right we have neoplastic cells. You can see the difference. The normal ductal cells, they are arranged in a honeycomb pattern. The neoplastic cells, they have very irregular nuclei. One very classic characteristic of pancreatic adenocarcinoma is the 4:1 atypia. So we have cells that are 4 times larger than the other cells in the same group. And this is one very steady, clear characteristic that I always use to make a final diagnosis of adenocarcinoma. For well-differentiated adenocarcinomas, this drunken honeycomb is very common. Sometimes it's still managed in honeycomb, but we call it drunken because the cells tend to be a little bit irregularly distributed, and they don't form the classical honeycomb pattern that we see in normal pancreatic cells. But if we look carefully, we can still see the 4:1. We can still see that some cells are 4 times larger than the other cells, and that is going to help us diagnose this case as a well-differentiated pancreatic adenocarcinoma. And here it's a bit more drunken, so this one had a bit some more tachyllas than the other one. And you can see here that the cells are larger, and you can see the 4:1 ratio, and this can be formally and steadily classified as well-differentiated adenocarcinoma. So in here, this is a moderate differentiated adenocarcinoma. You can see the 4:1 ratio a bit more clear. And as a matter of fact, here it's about a 5 or 6:1 ratio. Cells are very large. Again, moderate differentiated adenocarcinoma with the trunking honeycomb, already very trunking, kind of totally irregular. Some cells even have mucin in the cytoplasm. The poorly differentiated adenocarcinoma, of course, atypia is higher, and you have lots of necrosis, and this doesn't really impose a diagnostic dilemma. So for most of the times, what we usually have and what we usually face with problems are distinguishing between those low-grade neoplasms and also mucinous if it's low-grade or high-grade. But when we face with pancreatic adenocarcinoma, most of the times it's a straightforward diagnosis because most of the times the clinicians already know it's a carcinoma. They have all the morphological aspects in their imaging that say it's adenocarcinoma. Clinics is very characteristic of adenocarcinoma. Onset jaundice or some sort of other problems that come with neoplastic and patient has lost lots of weight. And then when we look at the microscope, it's straightforward. Most of the times it's going to be moderately differentiated or poorly differentiated, and there's not going to be any problems in making this diagnosis. So in here we see necrosis, that it's mostly commonly found in those patients. Here we have the 4:1, but as a matter of fact, in here it's 7:1, right? Cells are very large, very irregular, and there's no problem making a diagnosis of pancreatic adenocarcinoma in this case. Sometimes we can see mucin, and in here we have a pancreatic adenocarcinoma with mucinous component. This might represent one lesion that arise from a high-grade IPMN. So that's why I was saying in the past that when you make a diagnosis of a high-grade IPMN without any invasive component, you are potentially saving the patient's life. So here we have one adenocarcinoma that most probably came from a mucinous lesion. In this case here, we have the osteoclast-like poorly differentiated adenocarcinoma. Some cells have multinucleation and they stain positively for CD68. This case is a poorly differentiated adenosquamous carcinoma. So we have the adenocarcinoma component, and we also see keratinization and cells proved to be with squamous differentiation. In here again, so on the left, we can see the clearly glandular component, and on the right, you can see the squamous cells with keratinization. So this is an adenosquamous carcinoma of the pancreas that are usually poorly differentiated and have a worse prognosis for the patient. This is a metastatic lesion to the pancreas. We have to remember about metastasis because pancreas is most commonly affected by metastasis. Not all adenocarcinomas are primary adenocarcinomas. We have to be careful with that. And one neoplasm that often metastasizes to the pancreas is the renal cell clear cell carcinoma. So in this case here is a metastatic renal cell carcinoma. Those cells, as you said, as you know, in the kidney, they have foamy clear cytoplasm, lots of vascularization, mild atypia. And for those cases, we always make cell blocks. And in this case, the NHRase was positive, and the other renal cell carcinomas were also positive. PAX8 was positive. Well, so the management for those cases, of course, surgery whenever possible. Sometimes they are inoperable, and then you just deal with chemotherapy. And the risk of malignancy is almost 100%. So we make a very good case here for calling something positive. So we have all these categories to assure that when we call something positive, it's truly positive, and the patient has to be dealt as someone who has a very aggressive disease and with all due respect that the pancreatic carcinoma deserves. So that's why it's so important to have all these markers and all these characteristics of each different category very well organized in our minds, because when we call something positive for malignancy, when we say something is really malignant, we have to be sure it's malignant, and the risk of malignancy is going to be nearly 100%. Last important message from our lecture today. We are finishing 45 minutes, and what I have to tell you is our conclusions. So correlation with clinical and imaging findings is essential. So when you are doing pancreatic cytopathology, you don't do it by yourself. You always have the phone, you always have the message, whatever you need to communicate with the clinician, to look at the specimen, to look at the biochemical analysis of the cyst content, because your final diagnosis is going to be based on the biochemical analysis, on the clinical imaging, on the clinical findings, and the morphological findings on your slide. And all of these together is going to lead you to a final definite diagnosis. So always correlation. Benign pancreas. If you see benign pancreas on our slide, I always repeat that because that's very important. That is only negative if you have a vague mass. If you have a very well-formed lesion, that's not gonna be negative. That's gonna be non-diagnostic. So you have to be careful with that, right? And ROSE increases overall sensitivity and specificity for solid lesions. So it's very important for solid lesions that we do ROSE, because then we can culture those cells and divide the specimen in whatever we think is best. Cystic lesions require morphological, biochemical, molecular, and imaging approach, as solid lesions do. But specifically for cystic lesions, it's very important that you have all this information before you make a diagnosis. And immunohistochemistry is a great ancillary test, especially when dealing with those tumors that have a dispersed cell pattern population, and we have to distinguish between ACC, neuroendocrine tumor, and SPN. And for those cases, we have to have a cell block. So for those cases, immunohistochemistry is very important to achieve a final diagnosis. Thank you very much. So I spent 45 minutes here talking to you and hoping that that's gonna stick to your head for now. Of course, if you have any doubts or questions, I'm here. And thank you so much for bearing with this WHO Pancreatic Cytopathology summary. And thank you again, IAC, Diana, and Ivana, for the invitation. Thank you.
Thank you.